Thank you so much. Thank you, Ken. And how can I start without thanking Jeff and Rod? I remember it was just a few years ago, we were in this tiny room. Was anyone there? Right? This tiny room in Breckenridge, and here we are today. So thanks to all their hard work. And I am so honored to be here with everyone today. So we're gonna talk about type 2 diabetes. And actually, I hope that when I'm done here, I can convince everyone that low carbohydrate does work for type 2 diabetes and type 2 diabetes reversal, but I'm not gonna have to work that hard on that fact. But that it's not the only way, and that all of us who care for patients do need to understand that there are other ways for people to go about the idea of reversal. And we need to always remember that the ultimate choice about what a patient does for their health is theirs. And what we, so important, I think it's lost sometimes along the way, but our jobs are to be educated on all the options and to really be able to have a patient-centered discussion. Now, I fully believe, or I wouldn't be here today, that most people will choose low carbohydrate as an option because of all the reasons we know, but not everyone will, and that's okay. So let's go through it. First, my disclosures. I do work for Virta Health, and I am an advisor at Adkins, and I have a major intellectual bias. Major. And why do I have this intellectual bias? Because I've cared for thousands of amazing people who have had life-changing results. And you know what? You can't ignore it. So I declare it, and I hope that we can get to a place in medicine where we can be forthright with our intellectual biases, because it's the one that is the most powerful and the one that we hide. All right, so you guys have seen this slide. If you've seen me talk before, you know, we got a problem. Over 50% of the adults in this country have diabetes or pre-diabetes. So what would we call that? We would call that urgent, maybe emergent. But is it even worse? The answer, sadly, is yes. So here's a new study that came out to say, okay, over 50% diabetes or prediabetes, those are people who actually have problems with their glucose. But we all know that there are plenty of people who are insulin resistant and still have normal glycemia. And actually, the amount of those people blew even me away. So looking at NHANES data recently, what do we see? 12.2% of the adults in this country are in optimal metabolic health. What does that mean? Wait a minute, 88% aren't. 1 in 10. And when we look at the normal weight people, right, we think they're all fine, the normal weight people, less than a third of them were in optimal metabolic health. Is that urgent? Is that emergent? No. It's panic time. It's panic time. And here's my question. What is it going to take for the collective to care about this? If these people were spontaneously combusting everywhere, would we pay attention? Is that what it's going to take? This is beyond an emergency, folks. 1 in 10 of us are healthy metabolically. 9 in 10 of us are in trouble. We've got to do something. So how about the group of wonderful people who are here at this conference? What can we do about it? We can talk about what we can do. Whether you're a healthcare provider, whether you're a patient, we need to be talking about this fact. Type 2 diabetes is reversible. I like to think of it like this. When someone is diagnosed with type 2 diabetes, what they get put on in our healthcare system is a one-way street. A one-way street. And we can throw medicine and we can throw all kinds of stuff at them, and we may slow them on the one-way street, maybe to 30 miles an hour from 50. But even if we slow them for 30 miles an hour for a little while, what's gonna happen a year later? They're gonna be not at 50 probably, they'll be at 60 miles an hour. But the point is they're still gonna be on a one-way street, right? It doesn't have to be that way. We can open another lane to get them going the opposite direction. We can free them from the one-way street, and we have to understand the options to do that, the options to open the second lane, and discuss it with patients and let them know they have a choice. There's a way for them to regain control. So, how? 3 clinically ways proven in the literature to reverse type 2 diabetes: bariatric surgery, a very low-calorie diet, and a low-carbohydrate diet. 3 ways in the literature, well documented. So let's talk about bariatric surgery first. Here's the thing, folks, it works. It does work, up to 80% short-term remission. And in surgery, we've moved away from the gastric bypass surgery for the most part and are doing the less invasive sleeve gastrectomy. The 10-year remission rate is somewhere between 36, and I have on here 83%, but that really was attained from one study in the 90s, and no one's ever been able to replicate that degree of long-term remission. So probably somewhere in the 30s. And then I'm going to talk a little bit more about the STAMPEDE trial. It went out to 5 years. It's probably one of the best known surgical intervention trials looking at diabetes remission. And at 5 years, it was 29%, but they had a very conservative definition. So they weren't trying to get it under 6.5, they were pushing to get it under 6. So that's an important factor as we evaluate these things. It works, but, right? There's a surgery risk. I mean, many people will come saying, there's no way I'm gonna have surgery. And again, remember, patient choice, that's their decision. There's complication risk, and there's a big cost. We know that. But I think the most concerning thing is, does it really solve the underlying issue? So if mom or dad has bariatric surgery, is it gonna change what happens to the kids? Does it prevent the next case? Have we really gotten someone to so embrace the idea of nutrition changes along with it that we can help impact the next generation? That's probably a big concern that we need to think about. However, is bariatric surgery appropriate for some people? It is. And anyone who cares for people knows this is what's going to happen some of the time. People are going to try a nutrition intervention. It's going to fail them, and they'll wind up with surgery. And the flip will happen. Surgery will fail some people, and they will wind up in our nutrition-based clinics, and they'll thrive. So we just have to help people figure out what's the best place for them. But we have to also acknowledge the most robust data exists with bariatric surgery, and it can be successful for some people. All right, so how about very low calorie diets? They've been studied for diabetes reversal since the 1970s. And if we look at some of the most well-known trials, we see, one of the differences is the degree of calorie restriction. We go everywhere from like 300 to 400 calories a day up to Look Ahead, which went up to 1,800 for some people. So the calories differ, but again, they're pretty low in general. And that's an important thing to discuss with people if they're going to be working on reversal or remission as their goals. What does this actually mean when it's applied practically? Now, of course, the calorie restriction to this degree doesn't last that long, 3 to 5 months on average. The question is, can it work long term? And there's consistent issues with all of these studies with weight rebound when that extreme calorie restriction ends. And so here's a good look at that and the rebound that we get. So what I've got here is I've got a number of different studies, okay? So some with extreme calorie restriction, and then I've got 2 low carbohydrate studies. One, the study by Tay et al., so probably many of you are familiar. We've gotten 2-year data on that. And then also we have our Virta IU, which is the blue bar. And then everything else are the very low calorie diets. And what you can appreciate from this graph is, boy, when you're on that degree of calorie restriction, you lose weight really fast, okay? No one's gonna argue with that. It works in the short term. But the problem is, and it's well documented in the literature, when we lose weight that fast, we tend to have a more extreme rebound afterwards. And so you can see that in this graph here. And take a look at the bottom of the graph, which looks at A1C. And what you can see is when you have that extreme calorie restriction, you do lower A1C really fast. But take a look at down the road what happens. The A1C is not sustainable either. So this is the biggest issue when we talk about these very low calorie diets. So in summary, they work really well in the short term. The question is the rebound and what's going to happen long term. So now let's go to my favorite of the 3, and I'm sure many in this audience, which is low carbohydrate diets. So this is not just a few studies, okay? Low carbohydrate diets have been incredibly well studied for diabetes. 22 randomized controlled trials, 10 meta-analysis, 10 non-randomized trials. Look at this, this is a big one. There are a lot of studies with a lot of people in them that have lasted a long time. So it's not just that we have, as the ADA has liked to criticize in the past, short studies with just a few people. I mean, we've got robust data here. So a couple of the things when we're evaluating these studies that we have to keep in mind. The degree of support given with all these trials differs widely. Once a month, in-person groups, do people actually go to those, yes or no? Are people calling them at home? What kind of supports? And I think that we're gonna find out with that or with very low calorie. The support given is gonna be critical. And what it appears is that the degree of carbohydrate restriction matters. And this was very specifically pointed out in a recent meta-analysis. The lower you go on carbohydrate restriction, the better the diabetes remission and reversal rates. And I don't think that really surprises anyone. That's kind of basic physiology here, okay? But when we evaluate all of the low carb studies who are at least call themselves low carb, because one of the low carb studies, for example, that didn't show really good reversal rates, didn't perform that good compared to the control diet, called themselves low carb when it was really 40% carbs. So we need to be able to categorize these differently. The lower the carbohydrate levels, the better the results have turned out to be. So we just want to keep that in mind. So now I'm going to jump to our trial and talk a little bit about our new 2-year results as well. So I think many of you probably are familiar with this trial, so I won't stay too long on this, but just quick summary. This is a 5-year trial, and I'm really excited because we just started, like last week, our 3.5-year data collection. So numbers are starting to roll in. Yeah, so I can't wait to be here next year and talk about 3.5 years. And we're gonna have a whole number of other studies coming out of this that are really exciting to discuss in the future. But this was a big trial, okay? 465 people total. And of those, in the intervention group, 262 of them had type 2 diabetes. The others in the intervention group had prediabetes, and we will be reporting on those later this year. And one thing I'm gonna say here, and then I'm gonna come back to this really important point, the average time patients enrolled in our study had diabetes, these were all type 2 diabetes, was 8.4 years. We had a number of people who had diabetes for 20 plus years. Now, one important thing is if you look at the bariatric surgery literature, where this is, again, best discussed, is that one of the risk factors for reversal or not being able to attain reversal is length of time with diabetes. So just want you to keep that in mind as we go through the rest of this talk. So our primary outcomes were body weight, metabolic syndrome criteria, which again is what we're gonna be reporting on in our prediabetes paper, and type 2 diabetes status. So here it is, 2 years. What happened? We sustained the results. We sustained the results. And so, I mean, this is very exciting. So we reversed type 2 diabetes and we were able to keep people in reversal. We went from 60% at 2 years to 54%, over half the people in the trial maintaining diabetes reversal. That's huge. Just for one moment, imagine that was a drug, right? Do we need another drug? Come on, we need food. We need proper food. It works. And the medication reductions, they're staying incredibly robust, right? So these are people who are maintaining a lower A1C and still staying off drugs. And I gotta tell you something so exciting, and that is, in the last 6 months, so this is 3 years after these people started, I have taken 3 people who have a diabetes duration of 15 to 20 years off insulin. 3 years. It took 3 years for them to get off insulin, but they did it. And it begs an unbelievable question. What's going on with the recovery? They didn't get off like many of our patients do in the first couple of weeks. They had diabetes for so long and came into the trial on huge doses of insulin. But they were able to stick with it. And at 3 years, they came off insulin. I mean, you know, those of us who work with these patients all the time, it's so rewarding to tell someone that they don't have to take insulin anymore. But I will tell you, nothing has been more rewarding than to tell someone that after 3 years of their hard work and their diabetes of 15 to 20 years, you're done, man. You're done. It's so fantastic. We need to understand that better, but it's exciting. And so with all the medication reductions that we're having, we're saving a lot of money. This makes sense financially too, let alone the quality of life that we're giving to people. So 46% at a year in the medication cost reduction. Okay, so let's go back to this summary, big picture things. 91% at 2 years of insulin users had decreased or totally eliminated their insulin, right? 91%. At 1 year, we were at 94%. I'm calling that sustained success. And 74% were retained. And that number is amazing. We all know, the physicians in this audience, you prescribe a medication to a patient, there's no way they're coming close to 74% still taking that medication at 2 years. No way, yet we were able to sustain a lifestyle change at that degree at 2 years. And what's the average weight loss? 10% average weight loss at 2 years. So these are big sustained numbers. And let's take a look at the new data that we have coming out. Part of it's already been published, part of it is in review. What happens to liver fat? Because we know fatty liver disease, right, is taking over just like type 2 diabetes. It's a problem in quality of life, and it's a huge problem in cost in this country. So here we are with liver fat scores. 12 months down, 2 years down further. Huge. And let's take a look at this. This is all the liver related biomarkers, including what we have over here. Second to the right, that is central abdominal fat and how much it went down at 2 years. So what we have is across the board improvement in these markers of liver health. Whether we're looking at the liver function test, we're looking at fibrosis scores, I mean, they all improved. And this is a paper that we just had released. I encourage everybody to read it. This was just published in BMJ Open, looking very specifically at all of the markers of liver health. And the graph on the right basically is showing that liver function improves, and it is related to the improvement in A1C. So in other words, if your A1C dropped further, the chances are your liver function or markers of your liver health improved more. That probably doesn't surprise us. And here's another paper that we just published within the last month. Sleep. We all know how important sleep is to us, ourselves, right? And to our patients. And so patient-reported sleep improved significantly in patients with type 2 diabetes and also patients with prediabetes. And the interesting thing is the patients with prediabetes improved even more. What happened in our control group over the time period? They got worse. That doesn't really surprise us because they were on the one-way street and they're just progressing. So one other important thing is our feedback loop, utilizing beta-hydroxybutyrate as a marker of adherence. It's something that I think is so important that sets this trial apart from other trials because we weren't relying on what patients reported they ate. We were able to really know exactly what they were eating because if they had ketones, they were restricting carbs. And they had restriction in ketones and that was maintained. So they're still doing it. Oh, but it's not a randomized controlled trial. So we can dismiss it, right? As it has been dismissed by so many. Oh yeah, the results are good, but it's not a randomized controlled trial. I'm not gonna talk to you. Okay, so let's talk about this because we just had this week the release of the 2-year results of the DIRECT trial. Anybody know about the DIRECT trials? This was in the UK, and this was a very low-calorie intervention aimed at diabetes remission. So again, it's a really important trial for everyone in this room to know about. It's important when we talk about diabetes reversal and remission. It's an important option for our patients. And so we cannot dismiss this trial. It is very important. The result release got a huge hubbub, but let's talk about the comparison of the DIRECT trial and our trial. The DIRECT trial was cluster randomized. Ours was controlled. What does that mean in the differences? Here's what it means. Patients self-selected and knew the intervention they were getting ahead of time. It's the same thing. Now, if they were cluster randomizing it and the practices that they were choosing all had to get into the trial, that's one thing, but they didn't. The patients self-selected in. Our patients self-selected in. It's essentially the same thing, except for we had 2 sites and they had multiple. We had endocrinology practice as the control, And we had my medical weight loss practice at IU as the intervention. Patients self-selected in both. Direct study, again, had multiple sites where we had the two. We were able to measure adherence, like I talked about, directly and with certainty by beta-hydroxybutyrate. And the remission and reversal criteria. The direct study, it's a little unclear, because here's what it says. Defined as hemoglobin A1C less than 6.5 after withdrawal of anti-diabetes drugs at baseline, independent of status at 12 months. I'm not sure what that means. And also their original one that said that it has to have an A1C below 6.5 at 2 time points, at least 2 months apart. And it's very unclear if that actually happened. Maybe it did, but we need a little clarity on that. We are very strict in what we are saying reversal is in our study. A1C less than 6.5 without diabetes-specific medications, which allows metformin. And here's the deal with metformin. It's indicated for conditions outside of diabetes. And here's a really important question that we have to ask. All the patients who had type 2 diabetes are at risk for developing it again. We have a medication that is benign and cheap and will decrease their risk for reoccurrence. Of course, they have to keep up with the nutrition too. So whose choice is it to stay on metformin? Is it the choice of the study to tell everyone that they have to get off of metformin because it makes the numbers look better? We want to be able to say that this was off all drugs, because that would be the best idea if you're looking at the study group as a whole. But I'm the doctor for everybody in the study, and the numbers as a whole are great, but I am responsible for all the individual data points that make up the study. And it's not my decision to pull them off a drug that may have benefit for them. So the discussion with every single person is, here's the deal with metformin. You can go off or you can stay on. Let's have a risk-benefit discussion, and the choice is yours. And my question is it ethical to just pull everyone off because it makes the study look better? Or should we be mandating that in anyone who has had type 2 diabetes and therefore is at risk for developing it again, needs to be able to have the choice at the patient level where it belongs? So it's really important we think about that. And did patients in the direct trial take insulin? No, it was an exclusion criteria. Did we take insulin patients? Oh yes, we wanted them. And how many years did people have type 2 diabetes? In the direct trial, the average was 3 years. In our trial, 8.4. And for those of you who care for people with type 2 diabetes, that's 2 different diseases. We know it. So how did we stack up then? So let's look at these 3 options for reversal. So the sleeve and the bypass data is coming from the Stampede trial. Very low calorie diet is coming from the direct trial. And the purple, the low carb, is coming from our trial. So let's take a look at this. We know when it comes to A1C, surgery, as I said, up to 80% short-term reversal plummeted. They had much higher A1Cs to start with. But let's take a look at once we got down and these curves here. If you take a look, the low carb got the A1C lower, and it's maintaining that A1C. We're now tracking right with surgery or below. Important. How about weight? Let's take a look at ours. Remember I said 8.4 years? We took the sickest of the sick. Take a look at where our weight started off compared to everyone else, including surgery. Our patients were sicker, which makes this even more important and, quite frankly, remarkable. So what if you take and pull ours down, let's say, okay, maybe we started at a lower weight. We're really tracking right with surgery here. We're tracking right with surgery. Now, does that make surgery not a good option? It doesn't for some people. But what I'm gonna say is that low carb can do the same things. It's really important that we understand that. And low carb is now the standard of care. We are not some fringe diet. New guidelines out last October endorse low carb by the ADA and the EASD as a recommended eating pattern, and the new ADA standard of care. And I'm super pleased to report that they cited our trial when they made the change, putting low carb as a recommended eating pattern, and acknowledge that low carbohydrate is the only eating pattern that can have removal of medications. That's big, right? This is big. We are not fringy. The evidence doesn't allow that anymore. We are standard of care. So how do the eating patterns stack up with the other eating patterns that the American Diabetes Association still recommends? Here it is. With all, and we've done a systematic pull of all of the data, of all of the research. And here's how the research stacks up. Randomized controlled trial and meta-analysis in the light blue, other trials in the dark blue. And it's no wonder the standard of care changes. The evidence is there. And I don't know if anyone knows this, but the Department of Defense, the VA, have been recommending low carb for over a year now. And we look here and say the carbohydrate intake as low as 14% recommended by the VA and the DoD. That's important. And one thing I really want to point out is how the VA and the DoD came about in creating their guidelines. So I've got some important points here. They use the US PSTF methods. They're considering upgrading to GRADE, which is a really fantastic guideline for guidelines. They have a policy of transparency, and they did a systematic review. So here's someone who didn't do those things. This is the AACE, or the clinical endocrinologists. So this is actually from their new guidelines when it comes to nutrition, plant-based. Now, notice that even though this is from the new guidelines, this slide is actually from 2015. They haven't changed anything. Because, of course, there's been no new science out there, right? 2015. I mean, why would we bother looking? We know what's right. And so here is a really important thing that looks at what happens when you do a systematic review and you follow guidelines for guidelines versus when you don't. This is a study from the ACP, or the American College of Physicians, when they changed their hemoglobin A1C goals last year. What they did is they took the major diabetes guidelines and they graded them. And what we see here is what is dead last, the AACE, followed closely by the ADA, because there's not rigor in the development. These are not things done with systematic reviews. When we look at the VA and the DoD here, it's very high ranked because they followed the guidelines for guidelines. We have to ensure guidelines are based on rigorous evidence review. It's critical, especially when we're talking about diabetes, the crazy epidemic in this country and around the world. So doing proper scientific review is critical to getting good guidelines. So let's remember 3 ways to reverse diabetes: surgery, very low calorie diets, low carbohydrate diets. Talk with your patients. The decision is theirs. Thank you.